Good morning. It's my pleasure to introduce today Dr. Tobias Geith, who is the author of the paper that will be published in Radiology. And the title is Transient Bone Marrow Edema Syndrome versus Osteonecrosis, Perfusion Patterns in Dynamic Contrast Enhanced MRI with High Temporal Resolution Can Differentiate of Entities. Good morning, Dr. Geith. Can you actually tell us a little bit about yourself and tell the reader about your work and what prompted you to do this analysis?
So good morning. Thank you for being here. It's a great honor to me. So I'm one of the radiologists in the Department of Clinical Radiology at Ludwig-Maximilians University in Munich. And yeah, we've done this special project because my research group, which is led by Professor Andrea Bauer-Melnick, focuses on MRI and functional MRI and perfusion MRI on bone marrow. And in the past, we did several studies on vertebral body fractures and the bone marrow changes in that field. And therefore, we also thought it might be interesting to use the techniques on other areas like joints. And therefore, the differentiation of different kinds of bone marrow edema was very interesting for us.
Okay, so you're telling me you're not really MSK radiologist. I'm a little bit disappointed, but it's okay. So as you know, this is a very controversial subject in the field of MSK, with bone pathologists almost always thinking that there is no difference between the two entities, i.e. transient bone marrow edema and osteonecrosis. And they think that transient bone marrow edema is just the first step of osteonecrosis. So what is your comment here?
My comment is that in the past, there have been indeed controversial discussions on the subject, but it's very important to make an early diagnosis because the treatment of bone marrow edema, which is a self-limiting disease, and osteonecrosis is very different. And therefore, you should, on one hand, not to overtreat the patients with transient bone marrow edema on one hand side, and on the other hand side, you should not make a too late treatment with a patient with osteonecrosis, where you can also apply a cord decompression, for example.
Yeah, certainly. We'll come back actually to the treatment later on. But let me ask you a very quick question about your study. How long have you followed the transient bone marrow edema, and did all lesions fully resolve in your study?
Yeah, the patients were followed up for up to 1 year, and during that period of time, all of the patients with a transient bone marrow edema syndrome fully resolved. So it was indeed a self-limiting disease, and the patients with osteonecrosis had, on one hand, either a progressive disease or the state of the disease was the same as in the beginning. But
so I understand that all transient bone marrow edema in your study resolved.
Yeah.
How about actually, did you ever seen or have any examples of transient bone marrow edema outside of your work that progressed to osteonecrosis?
The problem is that maybe if there is a progress to osteonecrosis, it might not have been an bone marrow edema actually. Maybe it was misdiagnosed in the first moment. And for that reason, to overcome these difficulties, we did our study on this perfusion MRI, where we could show that we had two different patterns in these perfusion MRI.
Yeah, that is very interesting. And that's why maybe actually my next question would be, obviously, do you have, or can you tell us more a little bit about the pathophysiologic basis for your perfusion findings you're reporting for both entities?
So the perfusion findings were as follows. So in the group with the transient bone marrow edema syndrome, we could show that there was a small spot which was adjacent to the subchondral bone, which showed a high perfusion. And this spot of high perfusion was surrounded by an area of low perfusion and a prolonged mean transit time. This was the first part. And the second pattern was that in the osteonecrosis group, we had an area without perfusion, so there was almost no enhanced perfusion and no contrast uptake in the immediate subchondral area, which was surrounded by a rim of high perfusion. And this rim of high perfusion was again surrounded by an area of low perfusion with a prolonged mean transit time. So on one hand, we think, or this is the most probable pathophysiology, that in the bone marrow edema syndrome, there is a small spot of reparative tissue which might be due to insufficiency fracture. This is one suspicion, and this area has the potential to regenerate fully after time. So we have still a perfusion in this area, so it is viable bone, and this area is surrounded by a reactive edema. So the edema is non-specific. It occurs in osteonecrosis and it occurs in the transient bone marrow edema syndrome. And on the other side, in the osteonecrotic group, we have an area where there is no perfusion. So this is truly necrotic area, which is surrounded by a reactive rim and surrounded by this non-specific bone marrow edema part.
So that is very interesting. So now to me, I will maybe go back actually to what the pathologies are telling us, and that maybe the two diseases are actually one disease, and just what you said and what you explained right now, it's viable and not viable. So maybe actually this is a different stage of the same disease. So what you're saying on that?
So I would say that this might not be the case, because on one hand there is we did not have the observation that any of the patients with bone marrow edema syndrome did the change to an osteonecrosis. So this area was still viable and did regenerate fully after some time.
Okay, but maybe because you also take those patients from weight bearing, and someone will argue that not weight bearing will regenerate, will just keep actually a chance to the bone to regenerate and to heal. But while for osteonecrosis you didn't do that. But let me just ask you a question to me that is really intriguing. So I understand that there is actually a part which is viable and non-viable in the osteonecrosis, and to me, I'm actually interested to understand, in your opinion, what is the basis of the edema which is seen outside of osteonecrosis? Why do we have such a
This might be a non-specific reaction of bone. Maybe it's an obstructed venous outflow, and which causes increased interstitial space. And this is also reflected in the prolonged mean transit time. So the blood needs a longer time to pass this area. But there is, from our point of from which what we can derive from our study, we cannot differentiate the type of edema itself. So it's just something that occurs in both entities, and there is no. So we did not do examinations on the cause of the edema itself.
So most probably your bone marrow edema here of osteonecrosis, of actually transient bone marrow edema and osteoarthritis, because I'm interested in that, are different, because we know in osteoarthritis is much more microfracture and all the changes that you can see there. But what is important here, since we see actually both the edema and osteonecrosis, and some, of course, an early stage and then a late stage, mostly an osteonecrosis. So we lose actually our bone marrow edema. So since there are multiple stages of that disease, is it important for treatment to differentiate those stages?
It's important that you do a differentiation in the early stage, because in the early stage you have the possibility to do a cord decompression if there is an osteonecrosis, to prevent the progress of the disease. And this is the part where it should be reliably differentiated from bone marrow edema syndrome, where you should not do a decompression because otherwise you treat a self-limiting disease with an invasive technique.
Okay, let me go back actually to your technique, because our readers probably will, ask those questions. So it's three questions in one. And how complicated is the technique? Okay, and do you think that you need actually some kind of, a teaching or some kind of a software that you're going to use? And also, very important question, how long will take actually someone to do the analysis? So in essence, if you start to do this really from the technique itself, is it complicated? You need software, and what is the time that is required to have actually the analysis done?
Okay, so I would say that it's not very complicated. So the acquisition of the data itself usually takes about 3.5 minutes. So we used a twist sequence, which is a very fast angiographic sequence. And we sent the data to a personal computer. We used in-house built software called PMI. And this software is freely available, as shown in the references. So everyone can download that and use it for his own purpose. And the analysis of the data takes about 10 to 15 minutes. So you need someone who is trained in that. So you have to do, I think, 3 to 4 evaluations of some joints to know about all the steps, because this is the very early version of the software. So you have do some things by hand, but everyone can do that. And the analysis takes about 10 to 15 minutes. So after 15 minutes, you have results, and you have calculated the maps. They can be also implemented to the scanners, to your clinical computers, or you can also do it on a private computer as you want to.
Yeah, I'm personally very interested, because we see a lot of in my clinical work, we have a lot of osteonecrosis from sickle cell disease, and some of corticosteroids, etc., treating actually patients with lupus, for example. That's what we have, and I'm really very interested to understand what has to be done as a next step to make this really as a clinical practice. So I'm asking you really the question, personal question. I want to just understand. I know that other readers will do the same thing, but let's say I'm interested to this. I want to just start tomorrow. What I can do here to implement your technique?
So what you can do to implement the technique? So you want to implement the technique into your clinical routine.
Yes.
You just download the software, make the images, use a twist angiography. So you have to have a high time resolution. So we have about 3.3 seconds per image, and download the software. Take the images from this twist sequence from your packs onto a USB stick, put it onto your computer, and then you open them in the software. You look for the artery. You have to put a region of interest into the artery, because you have at first some images which are used for baseline, so without contrast, and then you see that in the artery the contrast media is enhancing, and you have to determine the steps or how many images were baseline. You have to fill it into a window of the software, and afterwards you just use the deconvolution analysis. You have to push a button, and then you get 2 images which show you a map of plasma flow and a map of the mean transit time. You can color code it, or you can look at it in black and white. And this image you need just for the assessment of the perfusion patterns, which then you can analyze just by a visual inspection.
Okay, so as I understand it, and please very briefly explain to me what is really the difference between what you are describing and using DCMRI and with those publications that we have and talking about really differentiating those two entities just using DCMRI by itself. So what is the difference here?
So we have images which you can assess on at one glance, and the other studies have needed to put regions of interest in certain areas, maybe the epiphysis or the metaphysis. They use circular regions of interest, which of course are not fully adapted to the areas with the changes, and this needs much more step. So we have just a map which can be assessed visually, and the other studies needed for a quantification of the areas of interest.
So you're telling me this is good news. Your technique is much more, easy and simpler than.
It makes it simpler because we radiologists are accustomed to analyzing images, and therefore we have images we can analyze, or we have this color-coded maps which are images. And it's easy, and you see the result on one glance.
Okay, so before we finish, I have really one important question. So you talk about two entities, transient bone marrow edema and osteonecrosis. But as you know, there is another controversy in the field of MSK, which is the subchondral insufficiency fracture. And most of the pathologists, they think that this is exactly the same entity. So, and SIF and osteonecrosis, or subchondral insufficiency fracture and osteonecrosis, are exactly the same. It's just we, as a radiologist, kind of given this, a differentiation from the point of view of that, hypointense line, which is irregular for osteonecrosis, and for subchondral insufficiency fracture, that line which is linear and subchondral. So clearly, what do you think about this? Did you do any experiment? Did you have actually, did you see some difference, or what's really your experience here?
I would say there is a controversy on whether the transient bone marrow edema syndrome is a kind of a subchondral insufficiency fracture, because in the patients with a bone marrow edema syndrome, in the past you did, because you had conventional radiographs or you had CT scans, where you did not see any fracture lines, and you only had this edema in the MRI images. And with the better MR techniques, you nowadays see also in the patients with a bone marrow edema syndrome some subtle lines in the subchondral area. And we also did see some patients with a transient bone marrow edema syndrome, which had these subtle hyperintense lines in T1 weighted images, which we also included in the transient bone marrow edema syndrome group, because we also think that the underlying pathology of a bone marrow edema syndrome might be a subchondral insufficiency fracture, which was not able to be detected in the past because CT resolution was too low. And also in the patients which we assessed, some had subchondral hyperintense lines in MRI, but they didn't see any signs of fracture lines in CT or radiographs. So I think this is the controversy. Maybe this is a entity which might be the same, but we don't have a histologic proof because we have a lack of patients who need hip or joint replacement.
I do think I've got actually new information here, but I have to say that the controversy is going to last for more actually, for more time, because here I listened to the pathologists again, and they have really this kind of controversy between subchondral insufficiency fracture and osteonecrosis. I add to that the transient bone marrow edema. So we're not actually going to resolve this today, and more to come probably between pathologists, radiologists, and others, and orthopedics. Thank you very much. It's been really a pleasure talking to you, and I hope that our readers will benefit from this discussion. Thank you.
Thank you very much.